All right, so we're going to go to the live case. All right, we're going to go to the live case. The live case is being presented, guys. Okay, from Columbus, Ohio. The live case is being done by Dr. Christopher Metzger. He's the System Vascular Chief at Ohio Health Riverside Hospital, Columbus, Ohio. Hi, Dr. Metzger. Karthik here. How are you? Guys,
Good, Karthik. Can you hear and see us
please
okay?
calm down. Go ahead, Dr. Metzger. We're
Karthik,
hearing
can
you.
you see and hear us? Yeah. Can you hear us okay and see us okay?
Yeah, we can hear you. We can see you.
Great. Well, welcome to Columbus, Ohio, and Ohio Health Riverside Methodist Hospital. We're honored and thrilled to be transmitting cases to New York Endovascular Symposium. So thank you and congratulations to PKU and the entire team there. Another great meeting, and thanks for having us. Before we start, we've got a wonderful, wonderful team that works hard on these live cases and every case. I want to introduce them first. To my right, my good friend, my good partner, operator extraordinaire, Dr. Michael Jolly. Okay, keeping me in line. Keeping both of us in line much harder than that is Corinne. Behind us, we have the talents of Liz, Jed, and Michelle. I had a brief moment there, but Jed, Michelle, and Liz. And then Carrie Ice and our team behind the scene does a phenomenal job of that. So thanks to everybody. All right, we have a really pretty good case for you. We switched the orders because I think this is better for the educational purposes, but you'll understand that when you watch our afternoon case. So let's go to our let's go to our slides here. All right, next slide, please. Here are disclosures. Mike, I'll help work on getting you some more disclosures here later. Okay, next slide, please. All right, this is a delightful 70-year-old female, severe coronary disease, prior myocardial infarction, EF 30%, and a defibrillator. Diabetic for 30 years, she's a non-smoker. She actually was in an Ivy League school in medical education and is really thrilled to be part of an educational teaching opportunity. She had left rest foot pain, had a little ulcer on her fifth toe. She would do some things to rub it and then noticed that there was a small wound and then some induration that got a little bit worse, and she came in. ABI was somewhat compromised, but it was called 0.6, but there was an absent PPG and a TBI of 0 on the left. She had an arterial duplex with a very elevated velocity in the SFA, and then occlusion throughout the entire left anterior tibial artery, the left posterior tibial artery, and then tardus parvis in the left pop, TP trunk, and perineal artery, which we'll see here in a moment. Next slide, please. MRI, small, early osteo, SED rate was up, but lactic was okay, white count's okay. CT angiogram confirmed what we just saw from the duplex. The AT's out its entire length, so is the PT, and there's high-grade stuff in the POP and the TP trunk and the perineal, and significant disease in the SFA. Podiatry's already seen her and did some debridement. She actually got symptom relief for that, and now we're here to optimize flow prior to what they're going to do is an elective fifth toe amputation tomorrow. Next slide, please. So in summary, again, delightful 70-year-old female, long-standing diabetes, ischemic cardiomyopathy here for multi-level PVD and intervention. All right, let's go to our fluoro, please. All right, there we go. So what you'll see there is, we use micropuncture access, everybody does. The aorta iliacs and renals are fine. They're pretty big vessels, even despite diabetes for 30 years, and they're all okay. This is just an Ansel coming up and around. Here are pictures. You can see that the SFA is actually bigger than what we expected in terms of diameter. Here's that there's plaque above that, and then there's significant stenosis in the mid-SFA. Distal SFA is pretty large, mild plaque, and really pretty non-calcified too. And then here's where we start getting to the action. And you can see that there's a little overlap from a geniculate there, but there's subtotal occlusion in the POP, the TP trunk. The AT's out there about 340. It's out completely. And the PT's out there as well. And then the perineal comes back via good collaterals here and has a little disease after that. And again, we'll show you a couple angulated views of that. Kind of subtotal occlusion there. And then you can see it comes back, and there's some disease after that reconstitution point and a big perineal. And then after that, the perineal does a pretty good job of reconstituting the angiosome that we'll be treating with a blush there, and it comes back to the pedal posterior tibial artery as well. We did some IVUS, and we'll show you those images and then get some opinions and then get to work here. So here you can see on the IVUS, we went down into the, oh, first of all, I'm sorry. Let me show you. It was a little bit of a challenge to wire. We had it was occlusive with just that little small 018 catheter. So Mike gave a great idea, bring that catheter back, leave the wire there, get a better picture, which we did. And then we were able to carefully wire that. It wanted to select the perineal. We told it to go the other way, and it nicely came. This is a command 014 wire into the perineal. We changed for a different wire, which we'll discuss in a moment.
On the side, please. We have to show the angiogram on the side, please.
Are we showing the angiograms, please?
No, you're not showing the angiograms. You're pulling it from the peroneal up?
Yeah. So can you see that? And were you seeing the angiograms I was showing? I was looking at the pictures.
We got it. We got it now. But I think we can see.
All right, so there's a still picture of it, and you'll see it as we go, too, so we can save some time to get to work here. Let's just briefly show you the IVUS. It surprised us a little, I have to say. So, Liz, let's start with the SFA. And go ahead and put the IVUS up, please. All right, so this is the SFA. Go ahead, Liz, play that, please. So it's a pretty big vessel. This is starting distal to proximal. And what you can see is really lots and lots of soft plaque, but nothing significantly calcified there. All right, let's go to the perineal, please. All right, here's the perineal. And it's a little disappointing that there is really pretty, and probably shouldn't be surprising, but what do you think, Michael? 360-degree.
Yeah, diabetic for 30 years, yeah.
Yep, and there it is, and circumferential calcium. And we got up to 3.5 to 3.7, maybe 3.8 when Mike was pretty generous with his sizing, and so he gave us a 3.8. All right, next we'll go to the TP trunk, please. And more of the same, just a little bit bigger vessel. I'm not sure that may still be the perineal. Maybe that's TP trunk, I'm sorry. Okay, thanks, sorry. Liz is correcting me, and she's always right, so I'll just say that's correct. And then let's finally show the popliteal, please. Why don't we give her 25 of fentanyl too, Jed, if you would. And in the pop, we can get up to 5.4 maybe on a good day with generous math.
Yep.
Okay. All right. So let's come live here, and starting out with the panel, we got one vessel runoff. Got pretty tight stuff, but pretty straightforward in the SFA. One vessel runoff that's super tight. So what do you think? We're proximal to distal or distal to proximal? What are we going to do when we start in the perineal, work our way back? And then when and if do we put in embolic protection system? So go ahead, and I'll let Karthik talk here.
Yeah, so Dr. Parikh and Dr. Matthews both have their armory on ready to speak, so let's start with them. They already grabbed the mics before anybody could, so let's start with Dr. Parikh.
No surprise there, by the way.
Chris, good to see you, and great case. I think
Likewise, brother.
I think it's all about how easily you think you can prep this. I think here you might have thought an atherectomy strategy was necessary, but I'm not sure that that's the case here. You can probably balloon back into the pop and then prep the lesion adequately. In particular, I think if you're going to scaffold the tibials now that we have options, you don't necessarily need to be too aggressive and worry about the embolic risk, given that it's a single vessel runoff. If your choice was to not to scaffold, then I think then all bets are off. Then you may be more aggressive with the prep. IVL is another option. The new E8 catheter is available. It's a longer catheter. You might be able to do that, but I'm not convinced that the calcium here is that thick. But it looks like you're reaching for the shockwave. So I'll stand corrected.
So. No, I'm not. Well, believe me, we had a chocolate. We were going to open this with a chocolate until we saw the calcium. And then we had Lori from Shockwave who came charging down the highway at, I think, 93 miles an hour because we didn't have a 3.5. We just had a 4. She just got here, but we're already prepped with a 4. So we're going to gently, ever so gently, and I'd be interested in the panel, if it's 3.8, good one, is 4 too much for the perineal? It may be. So, go ahead, 1. Yep, you're there.
All right, Dr. Metzger. So I think you're shockwave in the peroneal, as expected. I think, Dr. Matthews, you want to add something? Or?
Don't go up there.
No, I mean, for me, I mean, I think doing IVL is a very reasonable thing. As Sahil was mentioning, the thickness of the calcification is not that, that much, so you can probably get away with other type of vessel prep technologies like a serenator or other type of scoring balloon. I was actually thinking about laser for this because you would kind of get a hybrid effect here because you have all that soft plaque. You're able to debulk that, and at the same time, you'd probably be able to fracture that calcium as well. So I think that would be a reasonable option, and you can do it, forwards and backwards. So I think the need for embolic protection probably less, especially if you go with a very slow technique. You can really ablate a lot of that tissue right in front of that atherectomy.
3 atmospheres.
And the shockwave here is only going to help in the peroneal area, and that's where the calcification is. The SFA lesion seems more atherosclerotic purely than anything else.
So that's why this is a mixed morphology stuff. So using just IV alone may be insufficient, but as Chris mentioned, PTA, may do fine here.
All right, Dr. Zeller?
Yep.
Well, for me, it's a perfect indication for IVL. In the TPT and peroneal, we have medial calcification, which is concentric. This cannot be tackled by a scoring balloon. We have no intraluminal calcium, so therefore, that's the perfect indication for that combined with a DCB. And I'm pretty sure after IVL and DCB, there will be no need for a scaffold in this location. In the SFA, I agree, that's fibrotic disease. We can discuss using a specialty balloon for vessel preparation, but I believe just going for DCB is more than sufficient here.
All right.
I mean, what it shows is we have different ways to prep, and we don't have yet the algorithm for vessel preparation for final therapy. For me, it's a soft lesion. I think the ultrasound actually helps in that, and Rotarex will give me an actual debulking, and also with the aspiration component, because listen to the wire, right? It went really through very quickly. So to me, another way of prepping will be the Rotarex atherectomy thrombectomy combination plus DCB more likely afterwards.
Yeah, the only problem here is that, I mean, if this wasn't a 4, and I think 4 is stretching it a little bit in the perineal, we don't have a DCB smaller than 4 in the U.S. And so, Tomas, we're jealous of all the options that you have in Europe.
Yeah, but anyhow, if the reference vessel diameter is more than 3.5, then with a 4, there is no risk. Yeah, definitely not.
IVL is smaller than 4. Yeah.
Liz.
Chris, it's surprisingly the case is too easy for you. You usually do something more exciting. So the peroneal and CP, I totally agree with the IVL approach, and then you will see what you get with IVL, and then decide whether you need to stent this area, and you can just get away. I agree with you can use 4.0 drug-coated balloon, although there is no data. But if you have a new stent now there, you can probably use this stent if you have one. For the proximal in the SFA, I think it's a directional atherectomy and drug-coated balloon approach, but you need a filter for that.
Yeah.
Yeah, I think this case presents a difficulty when, in a perfect world, you'd have 3 different atherectomy devices in one machine, but unfortunately you don't. So I think I agree with Jay that, if you see the mixed morphology, it's not a heavily thick calcium wall. Maybe laser would be a good idea, but, I think the tibial is going to be the one you have the least amount of options in. So IVL here and seeing what you get with balloon, even with the 4, I think that's what I agree with. Good job, Chris.
Looks pretty good.
All right. So, Dr. Metzger, I think this is the post-IVL image. Looks good.
It's a post-IVL, and I think to Tomas's point, it really does a nice job of preparation here. And I think what we like here is there's no or very low distal embolization and little dissection, so it gives us an option. Right. I really, then the question is, do we DCB the perineal, or do we just DCB from the TP trunk up? Remember, we're just trying to heal a wound. I don't think we have to get super aggressive, but let's go with a 5 by...
So your dissection seems to be starting a little bit in the distal distal pop and extending into the TP trunk mainly, right?
Yeah.
Dr. Metzger?
You're right, and we could IVUS that if we need to. We could always scaffold just a TP trunk, okay?
Right.
Now, if we're going to scaffold anything above that, I would use a Sapera, and we would want to put the Sapera in first so that the mechanism with the nose cone wouldn't hurt the distal scaffold. And then we would think about, do we want a bioabsorbable scaffold or do we want a regular coronary, just given the size of the TP trunk, which is pretty big. So why don't we just do you want a DCB, the TP trunk, or with a 5? But is that 5? Probably not, huh?
4.
4.
And
All right.
Dr. Metzger, your plan for the SFA is?
4 by 100, yeah.
What's your plan for the SFA
So
lesion?
what we're going to do, thank you. Yep. Let's bring that 4 by 100.
4 by 100.
So our plan for the SFA is as soon as we finish this work, we're going to drop a distal filter in there, okay? A filter right above what we just worked on, because that is soft plaque. We got one vessel runoff. And what we'll do there is we're going to chocolate balloon with a 6, okay? And then we're going to reevaluate and see if it's a DCB or a Sapera.
Are you planning to IVUS now, or?
No, we're gonna do a DCB first, and then we'll see what it looks like and see if we need to IVUS.
Right. So do you want us to just go for a talk and then come back to you, Dr. Metzger?
Sure, as long as you come back. Yeah, and remember we got.
We'll be very excited to come
do
back.
some prep work for the next case. So yeah, we'll come back. You let us know. That's fine though, Carter. If you do one talk and come back.
Yeah, I like the excitement here on the panel. Everybody is just grabbing the mics to talk. So, Dr. Metzger, we will come back.
No, I love it. So come on that panel. Come on that.
So the next. So we'll get to Columbus. Can we put? Hi, Dr. Metzger. We are back.
That looks okay there.
Yeah, it's pretty short.
Hey, Karthik, you're coming in right with, let's see where that is right there. All right, fluorosave right there. And we're going to show you the IVUS in a moment. Stop the IVUS for a sec, please. And go live on your, and then go live on IVUS for a sec. Okay. And then fluorosave that. Let's see how long we can, because I think we could do just take a 4.5 or 4.0 drug.
Dr. Metzger, before we go with the IVUS, you did do DCB, am I right? You did something?
DC.
Yep.
Just give us an update.
Correct. All right. So one more run. Go ahead and go live with the IVUS. And record, please. And then, Liz, in just a moment, we're going to go back and. All right, that part all looks good there. Where we DCB with a bigger DCB. Okay, stop, please.
So the pullback is from the TP
I'm going to show
trunk.
you here in just a second, Liz. Yep. So I'm going to. Let's do this. You're correct. So Liz, go to not the run we just finished with, the one before that. And what we did is we IVUSed the perineal with the shockwave. That looked beautiful. See that? There's no dissection. Then we come above there, and there is a dissection there. Okay? And then it gets back to normal. Mm-hmm. All right. Now, what we did here is I'm going to show you the fluoro. Let's go back to our fluoro, please. And let's pick our size.
Show them the run.
Okay, so there, 16, 26, 36, 46. Let's get a Megatron, 4 or 4.5.
4.
We'll make it bigger. Let's get a 4 by 48 Megatron, please.
So you're planning to stent from the TP
and I think
trunk
what we're going
into the pop.
Just into the very distal pop. Okay. The anterior tibial is a thing of past anyhow. We would think about bioabsorbable, but then we're going to have to really look about the overlap, and we don't want to overlap them very much. Plus, the biggest one we have is a 3.5 or 3.75, and this one we can grow bigger. And so I think what we're going to do is just primarily stent what's going to be effectively the TP trunk, maybe the very distal pop. Then that's going to, I think, look very good. The rest was treated with DCB. And then after that, we'll drop our NAV6 and just quickly chocolate in either Sapera or DCB the SFA.
Okay. Panel?
So are we getting our stent, please?
Right.
Do you want to show them, Andrew?
Jill?
I think the issue here with bioresorbable is exactly what Chris said. The 375 is not big enough. He needs a bigger scaffold, and Megatron's got good radial strength, and he can further post-dilate it if he needs to. So the key thing will be sticking the landing, which I know Chris is an expert at.
All right. Dr. Matthews, you have it on.
Yeah, I mean, I agree. I mean, I would love for us to have larger resorbable scaffolds here because it'd be perfect for this. But I would definitely go with a coronary DS for this.
4048.
I think the question is, do we think the dissection is extending further into the distal P3 segment? Then in that case, sometimes you want to put maybe a supera first and then the coronary into the TP.
Dr. Baba?
I think this case really shows how important the IVUS is in certain cases. And the IVUS just showed us that not just significant dissection, but also residual areas of significant residual stenosis, which needs to be addressed. You cannot just leave it like that. And putting stent there, I think it's the right thing to do.
Let's take that smart mouth off.
Dr. Zeller, you have anything different to say or agreeing with everybody?
We could challenge the indication for a scaffold here. At least in the SFA location, we know that after DCB, there is some positive remodeling in the presence of dissections. So if this dissection is not flow limiting, what by angiography it is not, there is no absolute need for scaffolding the TPT. You could even wait and watch here for healing process of the vessel wall. So just for discussion here.
Right.
It's not a bad one because, again, the goal was to heal the wound. And so if it goes down, you can always potentially recanalize again down the road.
Right.
I love Jay, but I'll bite back on that a little bit. If you're treating these patients weekly in wound care, try to do whatever you can to get the best result on this patient that first time if you can, because it's a little bit of a time lag and nightmare when you wait 2-3 months to do the second one on these wounds. So if you think you could get a better result and it's a limb preservation patient, personally I'd say do whatever you think you can to get the best at that time.
I mean, I would personally treat the TP trunk. I'm not sure that I would scaffold the SFA or the distal pop rather, because I think that might be overkill. But definitely with drug and whatnot too, I think that should be sufficient.
So you're saying you would just focally treat the TP trunk, do not even bring it to the popliteal? That's the point?
Well, I would DCB the popliteal,
Okay.
but I don't think I would necessarily put a superior.
I think his goal Dr. Metzger, correct me if I'm wrong, I think the reason why you're taking Megatron is by any chance if you have a dissection in the pop with the DCB, you think Megatron can be expanded and you can overlap it with the supera? That's the plan?
Correct. So we're not going to, the last speaker, I agree. We've already IVUS, and the rest of the pop, toward Tomas's point, is not dissected. It's been treated with DCB. So we're just treating the part that had a significant dissection.
That's right.
So the rest is already treated with DCB, and we're going to leave that part alone. So if we were going to supera it, I would do the supera first. Yeah. Just because the nose cone, I don't want it to ding up this stent. But we can make this stent a lot bigger, and we will later. Let me give you an angiogram here.
All right. So that's a 4048. That's great.
Yes.
Looks awesome.
And we're going to make it bigger later. But right now what I want to do is that we're just going to go ahead and drop our NAV6 in, and then it should not take us long to chocolate, and either as a panel, pick either one supera stent or one Ranger DCB. So unscrew that.
All right. Looks good. So we're going to go back to the next talk, and we'll come back to Columbus.
Okay.
So, all right, we'll go back to Columbus. Screens on, please.
All right.
All right.
So, So Karthik, we've put the drug-eluting stent in the TP trunk, took an angiogram. Everything looked really nice. I think you saw that.
Yep.
I'll show you if you want. And then, so that was DCB in the pop and the drug-eluting stent in the TP trunk, and the perineal was just a shockwave lithotripsy. We put the NAV6 in down here. Here is that lesion. This is a 60 120 chocolate balloon, fully expanded, and nice long. We were both very patient. Corinne made us, and then we took that, and the idea was, what's this angiogram look like? And there are good choices all the way around. Here's our angiogram. There's two clear-cut dissections. The durability of a interwoven stent, especially a 6 or bigger interwoven stent, we know from Superb is 86.3%, greater than 90 if you do it correctly. We're going to try to do it correctly. So that's what we're going to do right now.
Right.
And let's just show us that. So we're going to, all right, Liz, right here, hit the view roadmap button. And in just a moment, we're going to take that roadmap off. Go ahead. Yep, perfect. And we may do that again. Go ahead and do it again, please. So this is just a distal end. We want to get it past the dissection. Okay, now take the roadmap off and go to 6-inch mag and fluoro 3. And why don't you Nick, show our hands here and the fluoro, please. So what we're going to do is really, the whole key, as everybody knows, on the interwoven stent is preparation and then magnification and go nice and slow. And if we've done our job correctly, this should really be one of the nicer stents, and it's got very good radial strength.
And it's a 120 stent, Dr. Metzger?
It's a 150, which may be a little bit generous, but sometimes when we do this, if anything, Karthik, I'd rather foreshorten it a hair because that'll work its way out. What we don't want to do is elongate it.
Yeah.
And so, Fleur, save that, please. And so we're just going to put this in, and then we can get you a picture, and if you want to finish the session. I really wanted you to come back, and thank you, Karthik, for doing that, because we got a really pretty interesting case for you all this afternoon.
You're doing a great
little bit
job,
of preparation time.
as usual.
Well, we appreciate it. We have a great team that puts all this into place. Mike, why don't you get dressed? I'm going to have Michael do that, and he'll even do it better than me. And if he doesn't, I'll take back over. That's never happened, by the way.
See,
I don't give it up.
you're going to compress it there a little
I
bit?
heard. Move the table slightly.
I think it's elongating a little bit.
Well,
No, I don't think so. I really don't, Karthik. You're tweaking Dr. Jolly, and I like that part.
Sahil is there, so I have to be careful about the elongation, and
It's all good.
Sahil is going to comment on it before he does. I thought
we're
I'll
not
just
gonna
make
have any.
something.
Not at all.
Compress it. Sahil, I think that's looking pretty good. Now, if you tell me I got to take over for Mike Jolly, go right ahead.
I didn't say that.
That's never happened. I didn't hear it.
I think I heard it.
I think it looks absolutely, this is almost what a teaching video should look like, and I'm just sitting back and watching now. You can't see, but I've traded places, and the first half of the stent was mine, the second is Jolly, and they both look the same.
I need something dry. It's really slippery.
I mean, the key thing here is your wire will come back. And so you're on nav 6, luckily,
Yep,
so
that's a
your
good
wire's going to be
point.
way down.
Yeah, that's
and
correct.
hopefully won't engage your filter and pull it back. So that's something for people who are not used to using this device. They just have to be cognizant of.
Usually
It's
you
a
can
beautiful
advance the
point,
wire a little bit.
and then now let's flip our...
You can keep advancing the wire a little bit.
Yep, and then-
but I think the wire is deep in the
Correct.
cranial,
Let
so
me
it's
put that
okay.
last.
There we go.
That's why also
There you
the
go.
benefit of the
All
nav
right, so
6
I got to
because
say,
All right.
free floating
take it back
filters.
from Mike there.
Yeah.
Now, hey, Sahil, towards your point, one of the things we do, and one of the beauties of the NAV6 compared to the others, is the wire and basket are independent. So when you move the wire, you're not moving the basket.
Yep.
And you have the opportunity to put the wire deep down to the foot, which is what we do. Let's go to 13 mag. You got it? Okay.
Great.
Okay.
There you go.
All right, let's give you a picture of that. Tighten up that if you would.
It's useful for this application and when working with fellows.
Based on the tape, it looks exactly 150.
Exactly.
Yeah.
Look at that.
That looks great.
Looks great.
And so I think for that, what we're going to do is we're going to IVUS. We can do that off screen. We'll IVUS and make sure we've got everything optimized with the drug-eluting stent that is fully opposed. Take pictures to the foot, and then we'll come back in the afternoon. It should be an interesting time.
Definitely. Dr. Metzger, anything from the panel?
Come, show us back here. Show us, please.
Look at that, Dr. Metzger. Nobody has comments over it. I just wanted to ask you, Dr. Metzger, why not just balloon it and do a DES? Any comments on that? Just
Balloon what? The
SFA, just plain balloon
Yeah.
PTA, and then do a DES. If the why do we?
I will tell you, 150 and longer for me, nitinol stent is still a nitinol stent, whether it's got drug or not. And I think the radial strength and the flexibility and conformability of an interwoven stent is as good as you're going to get. And you know from the Leipzig data, the propensity nearest match, it beat drug-coated balloon, it beat nitinol stenting by a pretty wide margin. So, and that's been my experience for a long career in an old man. So that's why I think you don't get those kind of results, especially if there was calcium. There wasn't calcium, so you could go either way.
Right. Right.
Although I'll different stand, there's been a comparison randomized controlled trial between Misago and Silver PTX, and it was equivalent. So,
You know, Dr. Metzger, I have to ask a question. Otherwise, PK won't put me back on the podium. You know. So.
Yeah, no. So do what you have to do.
All right, so
great-
I think
great job,
a
Chris.
great result. I think we'll see you back in the afternoon. Thank you so much and congratulations. Great job.